Fighting Blindness Canada's View Point is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by AGTC, Allergan and Abbvie Company, MeiraGTx, Novartis and Roche. We'd also like to thank Accessible Media Inc., our national media partner. Everyone here should download the AMI app, which is a fabulous resource. And you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
So there's two major types. There's augmentation. Augmentation started as you have a genetic disease, we'll give you the damaged gene back, but it's much broader than that, as referred to by the panel already. It can be to deliver a treatment. It can be, the COVID treatment is an augmentation gene therapy where you're delivering a vaccine. The second type is what I mentioned, is the newer type called genome editing gene therapy, where you don't add the gene back, you try to actually correct the mutation that is in the genome. And that is the newest kind of gene therapy. There are two types of genome editing therapy, and I'm just going to tell you right now, I'm not talking about germline gene therapy. Editing gene therapy. That's actually illegal in Canada and illegal in most countries. So what we're talking about is somatic cell genome editing. A little history. So we can roughly say gene therapy's been with us for 30 years. The first 10 years is the pink box there, and you can see no efficacy. Basically, people were trying to do gene therapy, but nothing was working. The second box is the next 10 years is yellow. Things began to work, but boy, there were downsides. So the most important of which was called Genotoxicity, which gave cancer to some of the children that were treated. And then came our most recent era, a little bit more than 10 years now, where we have efficacy and we solved that genotoxicity problem, and so we have safety well beyond what we had before, although not perfect. Last is the little blue box in the top right, and that is that genome editing that has just arrived. So, approved gene therapies. I'm going to talk about the FDA. The FDA is the Food and Drug Administration of the United States, and they are the group responsible for approving drugs. And gene therapy is considered a drug. So they do the approvals in the United States. There are currently 10 approved, FDA-approved gene therapy. And approved means marketing is allowed. With assuming you follow the label, you're allowed to deliver it as a safe therapeutic for a disease. So the two I'm going to focus on are Luxturna, which has already been mentioned, and Zolgensma, both viral-based gene therapies, but that's only two. There's a lipid nanoparticle delivered RNAi. And then cancer. Cancer is actually the primary target of gene therapy currently, not eye disease. Eye leads the brain, but overall, cancer leads all the gene therapies. So here's the list of all the different approved gene therapies for cancer. And these bottom ones are a combination of gene and cell therapy together. What is Health Canada doing? Well, as usual, a little slower than our neighbors, but we have 6 approved. They are a subset of the 10 that I've already shown you, so everything approved in Canada is already approved in the United States. The 2 I'm going to focus on, Luxturna and Zolgensma, are both approved in Canada for marketing. And then 4 of those cancer T-cell therapies are approved in Canada. So as I mentioned, I'm going to zoom in on a couple of examples every time I give you one of these lists. And here I'm going to zoom in on Leber's Congenital Amaurosis 2. Leber's Congenital Amaurosis is an early onset childhood retinal dystrophy. Without treatment, it results in first night blindness, loss of sensitivity, clarity, and eventually complete blindness. LCA2 is caused by mutations in the RPE65 gene, and it's inherited in an autosomal recessive manner. So it's one of our inherited eye diseases. Luxturna is the gene therapy for this disease. Patients receive a one-time bilateral subretinal injection of a virus that carries the RPE65 gene. So this is the classic augmentation gene therapy for the eye, where you're delivering back the gene that is missing. Now, this was approved, first clinical trials were a long time ago. This is the first published peer-reviewed paper, 2017. So I'm able to give you a little bit of an update on where do things stand for those individuals who are now kind of 6 years out from their treatment. Well, the results are very favorable. Improvement in ambulatory navigation, light sensitivity, and visual fields has been maintained. Overall improvements have been maintained 3 to 4 years, and this is actually a little out of date as well, so we're now running about 4 to 5 years. So what you're looking at here, let's see, give myself a pointer, one moment, please. What you're looking at here is baseline. These are the individuals prior to treatment. And then the green line are the ones that were treated. And this is their mobility under different light. So you want to have good mobility under low light. So they went from mobility only under bright light to good mobility under dimmer light, and have maintained it over all these years. This group, the original group was split. This group was asked to wait and be a baseline, so what happens if you do nothing? And so they did nothing with them, and after a year treated them, and boom, up they go to greater mobility. So in this paper, there's a series of these kinds of graphs. Here's the second one, light sensitivity. The group was the same to start with. The first treated group is there. The second treated group waited a year, and then there. So we're really pleased with this gene therapy so far. Remember, these are all very new. I don't want you to think that this is like aspirin that's been around for forever. That's not. We're talking 5 to 6 years, but still, things look very good. So I said I would do a non-eye example, and here I want to highlight spinal muscular atrophy. Spinal muscular atrophy is also a genetically inherited, a now neuromuscular disease. It's a combination of a problem with the brain and the muscle. So without treatment, symptoms, the children, before 6 months, they already are severely affected. They include worsening muscle weakness throughout the body, but most importantly, in the ability to breathe. And without any intervention, these children are all dead by 2 years old. If they're put on mechanical ventilation, they can survive a bit longer. The gene is known. SMA1 is caused by SMN1 gene and is typically inherited in an autosomal recessive manner. The gene therapy for this, again, gene therapy really wants to be one and done. So intravenous, one-time infusion that takes about an hour. And it's done, ideally, before the child is a year old. This was the first paper about this treatment, and I should have the year, 2017. So again, I can give you an update. Here's the most recent update. Again, these kids are around 5 and 6 years old. And the way this graph works, so the 5-year extension results are very favorable. Long-term favorable, first of all 15 children are still alive, right? That is the first success. They have sustained clinical durability of the therapeutic dose. So what you're looking at here is age of dosing along the bottom, their ability at the time of dosing, and then the little figure shows how the child is doing. Sitting up, none of these kids are on ventilators. Sitting up unassisted, standing unassisted, standing with assistance. So there's no question that younger is better. Better children do better. So they're in the upper group, these are doing the very best. Waiting longer is not as effective, but still is life-saving, and these kids are off their respirators. So those are the gene therapies to poster child for success. This one is also virus. The injection is into the bloodstream, so it goes throughout the whole body, including the brain and all the muscles. I do want to talk about failures. So, X-linked retinoschisis, XLRS, another one of these inherited retinal diseases. It's a little different than the others in that what happens is the layers of the retina, as I show in this picture, split. So instead of staying nice and tight together, they've come apart. And that's because of the loss of the gene RS1. Without treatment, this results in reduced vision, and it's caused by mutations in the RS1 gene, and it's inherited in an X-linked recessive manner, by which I mean boys, men primarily suffer from this disorder. There were 2 viral augmentation gene therapy. This looks an awful lot like LCA. Why can't you just put back the RS1 gene and it's going to be great? Well, another one of the supporters of this meeting, AGTC, funded a clinical trial. 93% of the patients had treatment-emergent adverse events, including 2 out of 27 had retinal detachments. So they delivered it exactly the same way we deliver LCA, for LCA, is a subretinal injection. They saw no improvement, and they opted not to follow up beyond 12 months. The National Eye Institute, almost at the same time, did their own experiment. They had 9 patients. They didn't see so many adverse effects. They had 1. Still, that's 10%, but not as many. The product was generally well tolerated, but they only saw cavities close, those splits close transiently in 1 patient, and no improvement in anybody else. So it looks a lot like LCA. It should have worked the same, and yet it didn't, okay? Myotubular myopathy 1. In many ways, a similar disease to that SMA1 that I told you that's been so successful at saving those little children. It is also a muscular wasting weakness disease, a combination of brain and muscle. It's life-threatening from birth. The kids have serious respiratory problems that limit survival, and the gene is known, MTM1, again, an X-linked recessive. So the initial results of this trial were very favorable. It's a virus. It's putting back the missing gene. It was delivered into the bloodstream, so it would go everywhere to the brain and to all the muscles. It should have worked like SMA1, and yet, and it did to start with. So initial results were promising. 6 patients who received the low dose and the high dose, one that saw a high dose, no longer needed ventilator support and could sit, stand, and walk. The high dose delivered in this trial was the highest dose of AAV virus, of virus gene therapy ever given in a clinical trial. And disaster struck. So the announcement of the stop of the clinical trial following the deaths of 2 patients. Then about 9 months later, a 3rd child died. A year later, just recently, a 4th child has died. So the gene therapy trial was stopped, so no more patients got it. But the patients that got it continued to be followed in great detail to try to figure out what the heck went wrong. There's some hypotheses not proven yet, one of which is the dose was higher. The children have a mild and not very, not thought to be impactful liver problem. Could their liver problem be changing the way the dose works? And then the last one, which I'm very interested in, is they started with older children. So SMA1 started with babies right away. For some reason with this one, they said, we're going to start with the older children and work younger. So the older children, because the doses per kilogram, got a lot of virus because they were bigger kids. And so maybe the dose response is not linear by weight, but the virus is more toxic as you give more, and so should be reduced in a larger body size. Totally a hypothesis. Okay, what's coming down the pipe? So there are so many coming down the pipe that I could only put a list together for you of ocular ones. There are literally hundreds of clinical trials going on right now. Diabetes, Alzheimer's, Parkinson's, those because I'm a brain person, all the muscle diseases, etc. So 71 for the eye only, and I'll just leave this up for a second in case your favorite or least favorite disease is listed here. The number on the right is the number of clinical trials, and these are ongoing. And note there that retinoschisis is still undergoing clinical trials, so new ideas, new ways of possibly delivering it. They certainly haven't given up just because the first 2 didn't work.
10 years ago, there was one clinical trial.
What? Well, yes, this is new stuff. Is Canada involved? Not very, but yes. Ontario is involved in a Leber Congenital Amaurosis 10 trial, and Alberta is involved in a choroideremia and a Leber's Congenital Amaurosis 10 trial, centered in the United States, but with patients being enrolled in hospitals in those 2 provinces. So I want to talk about genome editing gene therapies, the newest game on the books. And here it is, 33 ongoing clinical trials for CRISPR gene therapy. So what are these trials? Well, there's 7 that are in vivo based, the kind of therapy we've been talking about. One of them that I'm going to talk about in greater detail is for Leber's Congenital Amaurosis number 10. And then there's 26 that are a combination of gene therapy and cell therapy together. And so we still consider that gene therapy, absolutely, and I've chosen a sickle cell anemia as my second one to highlight. So Leber's Congenital Amaurosis in the gene therapy world, we're always thinking about number 2 because that is the gene therapy that I've already talked about, that we have in hand and has been so successful. But there's a whole series of these kinds of retinal dystrophies. They're very severe, typically impairment at birth or in the first few months of life, usually a different gene. So here the gene is CEP290. Now this is a gene therapy, a genomic therapy. So we're not going to put the gene back. What we're trying to do is repair the gene. So again, it's done with a virus because the virus delivers the repair mechanism. But here is that mutation that we don't want. And the repair mechanism is able to create a deletion and remove it from the genome. So this was the very first in vivo CRISPR genome therapy clinical trial that the FDA approved. And we do not have a peer-reviewed result for this one yet. All we have is a little bit of information from the company that is running the trial. So Editas has claimed that the first 2 patients are doing very well and have shown signals, they called it, of efficacy. So hopeful, that's where we are with that one. Sickle cell anemia. So sickle cell anemia is associated with episodes of acute illness, progressive organ damage, and reduced life expectancy. Some people remain without symptoms for years, while others do not survive childhood. Causative mutations are in the hemoglobin beta chain gene, and it's inherited as an autosomal recessive. So again, this is a genome editing therapy, and what they're doing is turning off the gene BCL11A. So why BCL11A? Well, the way your blood works is when you're a baby, you have fetal hemoglobin. Then BCL11A turns off your fetal hemoglobin, and your adult hemoglobin comes on. So these people with sickle cell anemia or beta thalassemia, it's the same story, their adult hemoglobin is defective. And so having the fetal one come back on would be very helpful. And so turning off the BCL11A gene, it's the gene that turned off fetal hemoglobin in the first place, so turning it off lets fetal hemoglobin come back up in the adult. And that is therapeutic. So the way this actually works is you do a bone marrow transplant. And you don't have to worry about immune suppression or anything, because you take the cells from the individual, you put them into culture, you edit them in culture, and then you put them back into the patient. Okay, so you're getting your own cells back, but now with allowing fetal hemoglobin to turn on. So they call this CTX001. You get to be number 1. Both of them used that in their first ever therapy of this kind. And here we do have a peer-reviewed publication, again, about the first 2 patients. Both patients are a year out. They're both doing very well. They both have gone a whole year without a transfusion, which is very unusual. And the sickle cell individual has not had a sickle crisis in that year, which for that individual is unusual. And they both have high levels of editing in their bloodstream and high levels of fetal globin. So everything looks really good for that therapy so far. So with that, I would love to take questions. Thank you very much.
So Morgan's going to come around, and if you've got any questions, and I know we're getting close to the break, so we'll do a few questions, and then I'm sure Dr. Simpson will be happy to answer more in the break if we run out of time.
Totally.
Okay, so thank you for this excellent presentation. So I've got a couple questions here. Are there risks of systematic VAS subretinal delivery, and is subretinal delivery safer? Also, about non-AAV vectors, are there any good vectors that might replace AAV vectors? And especially for delivering larger genes like ABCA4. Thank you.
So subretinal delivery has risks all to itself, whether it's done for gene therapy or anything else. One of the biggest risks is that that you tear the retina. The surgeon needs to be highly skilled. If you're having that done, go to one of the research centers of the big hospitals to have that done where somebody's had lots of practice. So that is not counted against gene therapy, so that is a technique used for other things as well. And so the complications of that have to be taken into consideration, but they aren't blamed on gene therapy because they are surgical complications. Yeah. Your next question, AAV, as you're alluding to, is a small virus and is incredibly safe as far as we know, with the exception of what I talked about there. But it is only able to carry small genes. People are trying, as you may well know, to take a big gene and split it into 2 viruses and put them both in. There was one gene therapy I showed there that used herpes simplex virus. That is a bigger virus. You could get a bigger gene in there. Not a lot of people are using it. It's not considered quite as safe. So that's the edge of research right now, is how to either make the gene smaller or make the virus bigger, one or the other. And then, of course, there's the genomic correction. So that is another strategy. When the gene is huge, could you attack it by genome correction instead of trying to replace the missing gene? Did I hit? I might have missed the third thing you said.
I think you covered them all.
Okay, yeah, yeah. Any follow-up? That's good?
I'm going to text my wife.
Other questions? Somebody over here?
Thank you for this wonderful presentation. My question is, you listed under ongoing gene therapy, there is some 13 ongoing initiatives for RP, retinitis pigmentosa. So my question is, what are the prospects of that? How difficult is that? And what's the pace of the new research and what's going on in that field?
Tough one. It's been a tough one. That's why you see so many. Everybody really wants to get that one to work. There have been failures. Unsuccessful attempts. I'm not an expert in that particular area. I know that all I did was review those, and they're all a little different. They're mainly using AAV. They're trying. So you asked about delivery. Subretinal delivery is the standard right now from a FDA approved. But everybody's trying to get intravitreal delivery to work because it's gentler on a damaged eye. And if we could get that, that's what we actually use primarily in mice. Those pictures I showed you were intravitreal delivery, because we think in the future only intravitreal, when we can get the viruses to work properly that way, will be allowed, because it's safer. It's much more like your macular degeneration injections, more similar to that. So most of those clinical trials that I saw in reviewing the literature here were of the intravitreal type. But no, I wouldn't say there's anything just coming out next week. Not at all. Sorry.
Is it because of the nature of the disease?
Well, and you know, I tried to give the 2 examples of 2 diseases that looked really similar, and yet one, the gene therapy worked literally the first time they tried it. And the first clinical trial for Luxturna worked. And yet, we're on trial like 6 or 7 for retinoschisis and haven't worked yet. So there's so much we really don't understand. Yeah. And RP would be in that second category right now. Yeah.
We have time for one more question, if there's any more. Oh, okay, coming back.
Thank you. There is a follow-up. What is the status of work to repair a defective gene at the RNA level?
Yes, so I talked about repairing at the DNA level. That is where most of the emphasis is right now. Repairing at the RNA level is less of an area. I didn't find anybody with that kind of approach doing any clinical trials yet, so I would call it still very much basic research. I think you would see for Stargardt perhaps a DNA level clinical trial prior to seeing an RNA level one.